You're listening to This Week in Cardiology from theheart.org on Medscape.
Hi, everyone. This is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for December 7th, 2018. This week, quality metrics, statins, Botox, smoking cessation, and evidence translation. First up is the tyranny of metrics. Measuring the quality of healthcare is a tough game, and in the United States, the U.S. News and World Report identifies best hospitals for cardiac and cardiac surgery. The question is, do these best hospitals actually deliver on their promise? It's an important question because just last month, I reported on a paper showing that Joint Commission surveys versus state or other agency surveys did not actually improve outcomes. So for this study, Harvard researchers performed a cross-sectional look-back study of about 3,500 hospitals. Basically, this was a comparison of 50 ranked hospitals versus 3,000 non-ranked hospitals. And their main outcome measures were 30-day death and readmission rates, adjusted, of course, for risk. Now, they looked at three conditions: MI, heart failure, CABG, and they also looked at patient satisfaction scores. And for death, top-ranked hospitals did better. They did better for AMI, heart failure, and CABG. For readmissions, however, the top-ranked hospitals, when compared with the non-ranked hospitals, were very similar. And for heart failure, readmissions were actually higher in the top-ranked hospitals. For patient satisfaction scores, they did better at ranked hospitals. But the key finding, and the reason I highlight is that 30-day readmission rates were actually higher for heart failure at top-ranked hospitals compared with non-ranked. Now, it's no surprise that outcomes are better at top-ranked hospitals, though I am not sure whether this is because the care is better or just the data handling and patient selection is better. But the 30-day readmission things really is important because readmissions looks like a really bad metric for quality. And I say this because another paper from this year, January 2018, by Gupta et al., and this was also Greg Fonerose and Clyde Lianci were authors on this paper. They found that among Medicare beneficiaries discharged after heart failure hospitalization, the implementation of the penalty, the heart readmissions penalty, was temporarily associated with a reduction in readmissions, but an increase in mortality. This really gets me because policy affects every patient. And if readmissions actually is a harmful policy, that would be a huge thing because every patient is affected by policy. So as a clinician, I can't change policies. The only thing I can do is talk about it and urge you to do it as well. And also to think that policies are interventions. And the solution, I believe, is one, slow adoption and caution in implementing such policies. And two, we need randomized controlled trials for policies before implementation. Second topic today is about statins, and Patrice Wendling has once again well chosen and well covered a crucial study in cardiovascular medicine. Swiss authors performed a quantified benefit harm modeling study for statins, and this included a meta-analysis of primary prevention trials, plus a preference survey, plus selected observational trials, and their ultimate goal was to establish at what cardiovascular risk does a statin benefit become greater than its harm. And it's a hugely important topic because the just-released cholesterol guidelines give emphasis to shared decision-making. But for that, doctors need to be informed well beyond the simple 10-year risk threshold. I mean, come on. We all know that it's not as easy as a binary yes, you need a statin, and no, you don't need a statin. I mean, does a person with a 7.4% risk really differ than a person with a 7.6% 10-year risk? No, of course not. These risks occur on a continuum of benefits, harms, and also competing causes of ill health. So in primary prevention, statins reduce cardiovascular events, and this is a good thing because not having a cardiovascular event may lead to a longer, better life. But in older people, there are many other competing causes of ill health. So older people may benefit less from statins because of these competing causes of death. And also older people may have a higher chance of having an adverse event from the drug. So what about the burdens of statins? While a young person may have more to gain, Professor Rod Hayward from Michigan has often pointed to the unknown unknowns of being on statins for 2 to 3 decades. He writes in a really beautiful editorial that I'll reference in this podcast that the null can never be proved, especially when it is something difficult to study, such as whether being on a statin for 20 to 25 years has no major long-term adverse effects. He suggests, for instance, could being on a statin for 25 years result in a 25% increase in decline in cognitive function, or a 35% acceleration in decline in muscle health associated with aging? These are the issues the Swiss authors are trying to sort out. So to quantify benefits, they used the trials, and to quantify baseline untreated risk, they used event rates from observational studies. To estimate the harms, which is harder because the statin trials were short and observational studies are almost certainly biased, they used a Bayesian approach that combined rates of adverse events from trials and observational data. But their analysis relied on an as-yet unpublished network meta-analysis from their lab, and of course this will be controversial. And they did consider such adverse events as hemorrhagic stroke and kidney injury and hepatic dysfunction, which the guidelines don't say much about. And to estimate patient preferences, they used a preference eliciting study from their group. And this used a ranking curve for patients that weighed the relative importance of avoiding an outcome. And finally, and this is the key point, is they used a benefit-harm balance index, and it was modeled after one used at the National Cancer Institute. And this model takes into account competing causes of death. And the differences in expected events with and without statin use provide absolute risk events for each benefit and harm outcome. They then weighted the differences by their respective preference weights and summed them to yield a single benefit-harm index. So this weight could be negative, that is, the harms are greater than the benefits. The weight could be 0, which is benefits equal to harms, or positive, meaning statin benefits greater than harms. And they define statins as having a net benefit if the probability of the index exceeding 0 was at least 60% and the probability of net harm less than 40%. Now, the results, the net benefit of statins requires a higher threshold of 10-year risk than the current guidelines, which start the conversation at 7.5%. The Swiss authors found, depending on age, that the risk thresholds for statin benefit started between 14 and 22%. And I'd suggest get your librarian to get you a copy of this paper. There's a beautiful figure laying out the net benefit calculations based on age versus 10-year risk. For the young, the net benefit of statin turns to at closer to a 14% 10-year risk, whereas the elderly, the net benefit requires a higher risk threshold of up to 21, 22%. Now, the main reason this approach requires higher thresholds than that in the guidelines is that the Swiss authors consider both benefits and harms and competing risks of death, whereas the current guidelines mention mostly just benefits. Now, this sort of thinking on benefit versus harm over the long term gets me thinking about what I believe is the most important statin primary prevention paper ever, and this was by Judith Feingold from Daryl Francis's group at Imperial College, and I'll link that and reference it in the podcast. It's called The Distribution of Lifespan Gains from a Primary Prevention Intervention. And Feingold's group developed a new method of calculating the probability distribution of gains in life and found that the statin 30% relative risk reduction was concentrated in an unpredictable minority of people. For example, the average gain in life for a 50-year-old with moderate cardiovascular risk from statins is only 7 months. That doesn't sound like much. But the Feingold model suggests 93% of people gain nothing from statins, while 7% gain a mean of 8 years. And for older people starting statins, the profile is similar. Most older patients gain nothing, but those that do benefit get large gains, albeit about 4 years instead of 8. Similar to the Swiss analysis, Feingold's method favors treating people for longer. Now, the other thing linking Feingold's paper and this Swiss analysis is the relationship to shared decision-making. The Feingold paper actually included a survey of people, and they went out to a bus station in London and asked people about what they'd prefer. And many people, they found, preferred a chance of a large lifespan gain to the equivalent life expectancy gain given as a certainty. So the key is to ask people what they prefer. Some people play the lottery, others do not, and will have different preferences. Next topic is on Botox for the prevention of AFib. Autonomic dysfunction almost certainly plays a role in AFib pathogenesis, and the autonomics are surely jacked up after cardiac surgery. The autonomic GP, ganglion plexi, the relay stations, may be a target for prevention of AFib. And botulinum toxin, or Botox, is a neurotoxin that blocks neuromuscular transmission when injected near the GPs, which are in the epicardial fat pads. This exerts an anticholinergic effect and may suppress AF. So 2 published studies in heart rhythm tested the efficacy of Botox for prevention of post-op AFib, or post-cardiac surgery AFib. The first study from Russian investigators, they reported their 3-year results of a small RCT, and Botox worked beautifully and remarkably resulted in lower rates of AFib even at 3 years. However, Duke investigators tried the Botox in an all-comers group of cardiac surgery, and the Botox did reduce AFib, defined as just 30 seconds of AFib, but the 31% reduction did not reach statistical significance. So one view of these 2 studies is that the neutral Duke study failed to confirm the remarkable results from the Russian authors. But I don't think that's right, and I think Steve Stiles' piece really gets at this. A, there were differences in technique. B, there were differences in definitions of AFib. C, there were different patients. The Russian authors used only patients with PAF before surgery. And D, perhaps the Duke study was underpowered because they had a 10% absolute risk reduction and a 31% relative risk reduction in AFib, and it was non-significant. Look, Botox for prevention of post-op AFib is intriguing. This is kind of cool. And the injection at the time of the surgery seems like a really easy technique, and none of these trials showed any harm. So I think we need a bigger, definitive trial. And so CV surgeons out there, here is your chance to do a real trial instead of these mostly non-useful propensity-matched observational studies. Next topic, smoking cessation. When I first saw the headline that ACC was publishing guidelines on smoking cessation, I thought, oh boy, do we really need another guideline about something so obvious? I mean, of course we should recommend not smoking, especially after someone has heart disease. I have a canned statement in which I tell people that quitting smoking will lead to improved platelet and endothelial function relatively quickly. I draw them a picture. I say they don't have to wait years to get the cardiac benefits of stopping smoking. I tell people who still smoke after cardiac events that they have 2 choices: stop smoking or live a very short life. And it's fine. If they are done living and had a good run, that's fine. But if they want to keep going, they need to quit smoking. I have not been a proponent of using drugs for smoking cessation, but when I read the guidelines and then went to the references, I may need to rethink that. The meta-analysis of RCTs suggests that bupropion and varenicline use markedly improved the numbers of people who quit. I didn't believe it, but then I found a Cochrane review, the same thing. There's benefit in the RCTs. Now, nicotine replacement therapy did not look to have as strong as effect. So I need to learn more about these trials, and I'm going to go back in and study it more, but these effect sizes surprise me. Now, other less controversial things the guideline writers say is that cardiologists should not defer smoking cessation to PCPs, and of course that is true. I mean, come on, we are doctors, not proceduralists. We have a chance to really help people by giving them smoking cessation advice. The guideline writers were mixed on e-cigarettes, but I am not mixed. E-cigarettes may be less harmful, but suggesting them as a means for quitting seems dumb, and it just belies common sense. Let me know what you think about this topic. I'm still not certain I have this figured out. Final topic today is a novel study on translating evidence at the bedside. When we apply evidence at the bedside, we have to decide whether a trial's findings apply to our patient. The question is, do we use that trial's entry and exclusion criteria, or do we use the average characteristics of the enrolled patients? So when Luke Laffin was a cardiology fellow at the University of Chicago, he and his mentor, Francis Allengott, had an idea that using the average patient characteristics in the trial was going to be better than using the inclusion and exclusion criteria. For instance, in the case of the SPRINT trial, which showed aggressive blood pressure lowering to 120 was better than 140, the patient in the clinic might technically meet the trial's inclusion criteria, but be poorly represented by the actual characteristics of the patients in the study. Or, on the other hand, a patient might have a single exclusion criterion, say diabetes, but resemble the trial population in many other ways. So using the SPRINT and ACCORD trial, which had open databases so they could get individual patient-level data, these guys devised a trial score based on 6 continuous variables: age, blood pressure, non-HDL, creatinine, and BMI. This allowed them to map how far each patient was from the average patients in 6 dimensions. They then got a bell curve of the distribution of trial scores and defined 3 regions, like the data-rich zone, anything below the 90th percentile. So picture the whole bell curve except the 90th percentile. Then a data-limited zone with scores between 90 and 97.5 percentile. And then the far right of the curve, which was the data-free zone with those above the 97.5 percentile. And their big discovery came when they compared trial scores with outcomes in the ACCORD trial. Now, the ACCORD trial was similar to SPRINT, only it studied diabetics and found no benefit in aggressive blood pressure reduction. But get this, about 1 in 3 patients in the ACCORD trial had trial scores that had them fall into the data-rich zone of SPRINT. In other words, 1/3 of patients in ACCORD were just like SPRINT patients on these 6 variables. And for these patients, the event rates were similar to SPRINT. Aggressive blood pressure was better. But for patients in the ACCORD trial that had trial scores suggesting they were in the data-limited or data-free zones, in other words, they were unlike SPRINT patients, the event rates differed. Lower blood pressure wasn't better. So I wrote an explainer column on this novel study looking at trial scores. And on a specific level, the trial score might allow us to measure how close a patient is to a trial, or it may allow us to compare trials. But on a grander scale, this gets us thinking about a lesson that Dr. David Sackett taught, that evidence must be used judiciously and it must be tailored to the individual patient. So congratulations to Dr. Laffin and Dr. Allengott on this very important study. So that's it for this week in cardiology. I'm grateful that you listened. If you like this podcast, please consider subscribing, writing a review, giving us 5 stars. This really helps other people find it. Until next week, this is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org on Medscape.